try not to write on the presentation. It disturbs other people. And also, please complete the pre-test survey, which is being posted in the link in the chat box. And then later on, you will get a post-lecture assessment and an evaluation form. All three are essential for us to be able to send you the certificate of attendance. Thank you, and over to you, Dr. Rania.
Thank you, Dr. Neha, for the introduction, and good morning and welcome to everyone who took time to attend this presentation. So today the topic is dear to the heart of every single pediatrician. It's the routine vaccination. And we usually hear talks about what we know about the vaccine. Today we'll talk about the thing that parents know about the vaccine, not us. Those myths that the parents will come and challenge you with regularly in your clinic. And what are the facts behind these?
Dr. Rania, you're on mute, sorry.
Okay, sorry. I'm back with you. So today we will discuss the myth that the parents had as a concern about the vaccine. What are the bases? What triggered those rumors and how to deal with this? Because we know that vaccination is one of the top public health achievements of the 20th century. And we are very lucky to have this opportunity and will need to take all the chances of the vaccination and getting the most out of it. Why parents have concern about vaccine? Because they have concern about the safety of the vaccine more than the disease that these vaccines are designed to prevent. Because most parents were not aware of this disease. The diseases has been out of the market, if we want to say, for years, and they think that there is no way we can get those diseases anymore. But we all know that these vaccine preventable diseases are a short plane flight away, which the best example is the measles outbreak that restarted recently. So to be able to maintain a high level of immunization in our patient, all pediatrician, family physician, and anybody who works with vaccination should be aware of a risk communication with parents. So let's start by the big confusion of when is the vaccine contraindicated compared to the vaccine that can be given but with precaution. So we'll start with the definition. The Advisory Committee on Immunization Practice of the American Academy of Pediatrics differentiate the contraindication being a condition in the recipient that will increase for sure the risk of adverse reaction. Big example is anaphylactic reaction. We know this is going to cause harm, so it is not advised to be administered. While precaution is a condition in the recipient that might increase their risk of side effect or might not mount a good immune response to the vaccine. And at this point, we can give the vaccine, we might delay the vaccine, but only in case of outbreak, we disregard precaution and we still give the vaccine. So the contraindications are few, really. We all know that the rota vaccine cannot be given with severe combined immune deficiency and the previous history of intussusception secondary to a rota. The live attenuated vaccines are not recommended with a severe, and I repeat, severe immune deficiency. Previous history of encephalopathy with pertussis will prevent me from using a pertussis vaccine again. Anaphylactic reaction to a component of vaccine is a contraindication. And hypersensitivity to yeast is a contraindication to hepatitis B and HPV. But other than that, no major contraindication to vaccine. While precautions are a little bit more tricky. So lots of parents will come and say, no, I delayed his vaccine because he had a cold. And they keep having cold after cold and keep delaying the vaccine. Well, the normal and mild to moderate upper respiratory tract infection or febrile illness, regardless of the reason, are not precaution or contraindication to vaccination. Only moderate to severe are precautionary measures and should be delaying the vaccine. One other precautionary condition for the vaccine is a personal history of seizure with the MMR-V combined vaccination. So a recent study found an increased risk of febrile convulsion in children who received MMR-V compared to MMR alone and varicella alone. So a family history of seizure would tend me to give the MMR alone and varicella alone. the receipt of a live attenuated vaccine within the period of 28 days or 1 month would delay the other live attenuated vaccine. And definitely if we received any antibody containing products or IgGs. So now there are special conditions that we should be knowing about. What about if the patient is taking antibiotic? And this is also another major reason why parents are delaying the vaccination, considering that taking antibiotic will delay the vaccine so that they mount a good response to the vaccine, which is not true. Only oral antibiotic can interfere with the oral BCG, which is not available in UAE, or the oral typhoid vaccine. And these two vaccines are not in use currently. So oral antibiotic can be given vaccine without issue if the child does not have severe febrile illness. Now, what about the patients who are using antiviral? If the patient is using antiviral and we are planning to give a live attenuated influenza vaccine, this antiviral should be stopped 48 hours before taking the live attenuated vaccine. After the live attenuated vaccine, also defer the antiviral for 2 weeks. Now, for the varicella specifically, an anti-herpes vaccine specific, anti-herpes medication specifically should be stopped 24 hours before the vaccine. For the others, it's just 48 hours. Now, what about preterm? We also see lots of preterm who has been delayed for their vaccination and the schedule being postponed to the corrected age. This is not true for all vaccination. This is only true for the hepatitis B. Other vaccines should be given regardless of the weight for gestational age or the birth weight. Only for the hepatitis B, we differentiate those who are more than 2 kilos, and those will be considered as a regular newborn, and those below 2 kilos at birth, and those preterms below 2 kilos should be differentiated in those who had a mother who is hepatitis B surface antigen positive, and this one should receive the vaccine on time, along with the immediate immunoprophylaxis. Or if the mother is hepatitis B surface antigen negative, then I can give myself a 1 month and then start the hepatitis B vaccine, and this has been shown to boost a better immune response. Now, the egg. The egg allergy is common, not uncommon, but the egg anaphylactic reaction is very uncommon. Egg is really contained in big amount in the yellow fever vaccine. And that's why this vaccine, if there is a history of egg allergy, it is better to refer to allergologist before giving that vaccine. While it might be contained in influenza, MMR, and rabies, but the amount is not big. And a recent CDC study found that all the rates of anaphylactic reaction were not more than 1.3 per million. And definitely the influenza is one of. If you have a previous severe allergic reaction to an influenza vaccine and you are known to have egg allergy, yes, avoid. Otherwise, we differentiate those who have a cardiovascular compromise with the egg exposure, which is anaphylactic reaction. And these people should be referred to allergologists, vaccinated in hospital setting, and being ready for their reaction post-vaccine. While those who can eat cooked eggs or they have eggs but only with hives, they can be given the vaccine safely without being in a hospital setting. Now, what about the gelatin? Gelatin is contained in so many of the vaccines that we use every day. Influenza, MMR, typhoid, rabies, varicella. So if there is a gelatin allergy that is known, we allow precaution, but it's not contraindicated. Whilst Baker's yeast, if it is known that you have a Baker's yeast allergy, you should be avoiding completely the hepatitis B vaccine and the quadrivalent HPV vaccine. Latex allergy, there is 160,000 vaccine-related reaction reported, and only 28 cases had an anaphylactic reaction to a known latex allergy. So the risk of allergic reaction, possibly due to latex contamination of the vaccine, appears to be very low. And if it happens, it appears to be related to the rubber that is on the top of the bottle of the vaccine or on the syringe. So if the patient is known to have an anaphylactic reaction, you can use, but avoid the rubber and the syringe and use a non-latex containing rubber and of the bottle and syringe. If non-anaphylactic, no need to take any precautionary measure. Another challenge is the immune deficiency and the use of live attenuated vaccine. And we know the immune deficiency can be of several classes. There are the antibody deficiency, selective IgA deficiency, T cell, phagocytic cell, and complement deficiency. And only few are not allowed to take live attenuated vaccine. Antibody deficiency, they will not mount a reaction, and no live attenuated vaccine. T cell deficiency, other than diGeorge, they will not mount a good response, and those are not allowed to take a live attenuated vaccine. Otherwise, it can be given. This is for the congenital immune deficiencies. Now, what about the induced, the post-chemo? If it is a post-anti-B chemotherapy, then better to defer it for 6 months because we don't have a good response to the vaccine. If it is non-anti-B, then we can use after 3 months only. While with HIV patient, it depends on the on their ICD-4 to ICD-10 rate, and if it is CD4 for 15 and above, we can give the MMR and the varicella. Otherwise, no influenza, no MMRV, and the rota is normal, can be given. Another challenge is those living with an immunocompromised patient. Are they allowed to take a live attenuated vaccine? Well, yes, except if this immunocompromised is a stem cell transplant recipient within the last 2 months. So if it's a stem cell transplant recipient, we delay that vaccine for 2 months. Or if he had a graft versus host disease, then we have to delay or avoid the contact with the child who received a live attenuated vaccine. Patients with severe combined immunodeficiency, if a live attenuated influenza vaccine was given, this person should avoid contact with the child with severe combined immune deficiency for at least 7 days. These are the special conditions that we encounter. These are medical conditions. Now, what if the parents have concerns and fear, but there is no contraindication, no precaution to the vaccine? So medically, there is no issue. One study done in, published in Pediatrics in 2010 looked at what were the reasons parents refused to give the vaccine. And in fact, more than 55% of the response was fear of severe adverse reaction. Less than that, 5% had fear of autism. And only 10 to 12% refused it just for no reason. So behind that parental concern, it's always a serious harm to the child that is causing their concern. So if we can address these concerns, we increase the number of vaccinated children by 75% at least. So how did we get there? It's not without any real vaccine risk that we reached this point. Lots of vaccine were initiated, then removed from market because of serious reaction, like the encephalopathy from the pertussis before we started using the acellular one, the Guillain-Barré from the first influenza vaccine, the paralysis from the actual oral polio, intussusceptions with the rotavirus, and the actual measles with the killed measles vaccine. So the public health authorities reacted. This was not left. We transitioned from pertussis, whole cell pertussis, to acellular pertussis. We stopped using the OPV at 2 months. We introduced the injectable polio until the age of 6 months. The first rota was withdrawn. We eliminated the killed measles vaccine. So the public health took reaction, but parental refusal of vaccine remained increasing. And this study showed that 22.8 time increase in risk of pertussis at the time where people had this rumor going on and on about the pertussis causing encephalopathy. Similarly, the varicella was causing the actual varicella infection, and 8.6 time increase in the risk of varicella happened initially. So these are things that we hear about vaccine. So parents will keep saying, how do I know that this vaccine will not harm me, will not cause me side effect, will not cause me autism? How do you tell that getting vaccination will give me an immunity better than having the disease itself? I'm young, I can fight the infection. Others would say, oh, well, I've never heard of any polio case. Why you're still giving me polio vaccine? So these parental concerns or parental hesitancy are the main reason for not taking vaccine for children. And the major one is this vaccine going to cause me autism? And this question, years and years after the trigger or the flame, we are still hearing this rumor. So what happened? Why MMR was associated with autism? Why this rumor started? So if we look at the numbers, in the 70s, 1 in 2,000 children had autism, while in 2015, 1 in 150 children had autism. So there is a sudden rise. What happened? What caused this rise? Is it the vaccine? Because this is done when it was introduced, or a lot of other things that were introduced, like GMOs, pesticides, Wi-Fi, cell phones, electromagnetic fields. A lot of things were introduced. What was the thing that triggered the vaccine being the blame? It was a study published in Lancet by Wakefield that postulated that pervasive developmental disorder is associated with the use of MMR vaccine. Because the Lancet is a well-known and reputed medical journal, everybody believed and the flame started. But what is the rest of the story? These findings were never reproduced in any other study. Wakefield was found to have serious financial conflict, and actually 10 out of 13 authors, they retracted from and withdrew from this article. Few months later, the Lancet retracted the paper, the Wakefield was sanctioned, license revoked, and a new published article in the same journal retracted the previous article and reported being biased and not true. But this rumor remained in the head of people, which triggered lots of study later on to prove that this was not true. So one big study in Denmark took a large number of patients, around 2 million people, and they followed them between 91 and 98 birth, and they followed them until the year 2000. And the relative risk of autism was not increased in those receiving MMR compared to those not receiving MMR. Again, another proof of that would, if you look at the number of people who are vaccinated with MMR, it is being steady over years from 88 to 93. So this is the same number, the line is still steady, but the number of patients with autism is still increasing and rising. This study was in UK, another similar in California. So the autism is still ongoing, still increasing, but the rate of vaccination is the same. So what is happening? Is it safe to give the vaccine? Is it related? What in this vaccine is postulated to cause autism? A lot of theories. One of them is the glycophosphate in GMO. And this is also triggered by a study published by Stephanie Sneffen. And it postulated that glycophosphate is linked to autism because glycophosphate is introduced at the same time of the increase of the autism. And this glycophosphate is present in the vaccine. But lots of studies after that showed that this is not true and it has very low toxicity. But Sneffen is one of the people who are anti-vaccine population, and she had targeted a large population by her videos and the articles in journals, and her words were very well heard. And this is the proof that what she did is she demonstrated that the use of GMO increased at the same time as the increase in the autism. But if we go and check the trend of use of cell phones, also it increased in correlation with the increase in the case of autism. So who said that this is a causation effect? Nobody can prove that. Anyway, this article was retracted and she was attacked by so many vaccine pro population. So what is the latest evidence about the autism and the MMR? And JAMA Pediatric in 2015 published an article explaining the increase in prevalence of autism disorder and why it has happened. They took 64,000 children born between 1980 and 1991, and they followed them till 2011. Many were diagnosed with autism after 95. But why after 95? Because there was change in reporting practice. Before that, the criteria for autism were very limited, and in 1994, it became an autism spectrum disorder. They joined a lot of symptoms that were not considered before autism, but now are considered autism. And they included outpatient visit. This is also correlated with the DMS-3 being changed to DMS-5 with the introduction of the 1990s. And in the DSM-5, autism spectrum disorder included all age group, not only people above 3 years of age. So the number of population to be included or diagnosed with autism has increased to cover people below 3 years, and the number of symptoms to be considered an autism has increased. And this has caused the same time in the 1990s increase in the autism diagnosis and the introduction of the MMR, which is not a causation effect. Now let's look at other adjuvant in the vaccine. Are they related to the autism? 3 components in the vaccine were highly culprit: the aluminum, monophospholipid A, and the thimerosal. The aluminum salt is present in vaccines since 1930s, before even the diagnosis of autism was postulated. It's present in so many vaccines, and a majority are of the mandatory schedule of vaccines, so everybody has had this vaccine. Why it's added? To build a stronger immune response in the body. And in fact, it is a metal that is found in nature, in food, in air, in water, in everywhere. And the FDA had reported that the aluminum present in vaccine is very low. It mounts a better and stronger immune response without causing any harm. So this is removed. Is it the monophospholipid A? It is also present in vaccines since long. It is tested and reported to be safe by the FDA. While the big talk is about the thimerosal. Everybody talks about mercury and the injury to the brain and avoiding vaccine because of that. Actually, we need to know that the mercury is 2 types, the methyl mercury and the ethyl mercury, and they are very different. The methyl mercury is the mercury that is present in fish, and this is the one that is toxic to the brain. While the thimerosal, which is the ethyl mercury, it is very easy to clear from the body, much easier and quicker than the methyl mercury, and it causes less harm. Why it's added? To prevent bacterial and fungal overgrowth in the multiviral vaccine, which are in here, not in use. But we might be coming from countries where they use the multiviral vaccine. Lots of data from many studies shows no evidence of harm with the thimerosal amount that is present in the multiviral vaccine. And most side effects of that are just a local reaction, little redness, little swelling at the site of infection, but no toxicity secondary to that. But still, because the rumor increased and because of the fear that stopped people from giving the vaccine, it was removed from most childhood vaccination as of 2001. And still, the autism rate continued to increase. And actually, according to Stephanie Stephan, if her talks are true, but she postulated that by 2020, 50% of population would have autism. So 2020 is there, and we are not yet autistic, so her theory is not correct. Another parental fear is about the influenza vaccine, and we face a lot of patients refusing to take the influenza vaccine, saying it made me sick, it did not give me any protection. Even the CDC reported that. And we all know that the influenza virus, like other viruses, they have antigenic drifts and antigenic shifts. The drifts are common. It happens every year. It is usually expected from the season before, and that's why we introduce in the vaccine whatever is considered most probable antigen of the vaccine, of the virus. While the antigenic shifts are less frequent and it causes pandemics, not any like the pandemic we're living now, but an example is the novel H1N1 pandemic, which happened in 2009. So what happened in this season of 2014-2015, where even the CDC itself reported a very low response to the vaccine, which triggered the people to start fighting. And we all know that before the 2015, it was much easier to convince parents to take the vaccine. While from that year and on, since CDC postulated literally that they had the lowest effect, which is 10%, people started complaining and arguing about the vaccine. What happened that year? It's actually that they put the influenza A, H3N2, that was supposed to be the most common antigen of the influenza for that season. But specifically, they included the clade 3C2A and 3C2B. These were the strain included in the virus that circulated, while the vaccine had the clade 3C.1, which caused a non-good response. But for those people who were used to take the vaccine yearly since 2012, they mounted a better response and they did not have the disease because it's a cumulative effect. The clade 3C.1 might have been one of the antigenic effect of the years before. And in fact, it was the one that was common in 2009. So those people who are taking regularly and every year the vaccine were supposed to mount a better response to whatever is the clade that is included in this year's strain. People would say, I am young, I am having strong immune response, I eat well, I exercise, why to take the vaccine? I can mount a better immune response if I get the disease. Well, this is not without any price to pay, and a real price. And we looked at the death from vaccine in the period of the 1976-77 and compare it to 2006-2007, and the number of deaths has increased tremendously from 3,000, which was at that time a benign influenza, and everybody would say, oh, I had only the flu, to 49,000 annually in 2006-2007. And the majority are children, elderly, and it is going to affect in both not only the amount of death, but also the sick leave days and the decrease in the economy and the burden on the community. So our message to the parent concerning the flu, in the fight to prevent the flu, your best shot is to take the flu shot. And that's what we are every year trying to push our patients to do. And this year, more than any year ever, we need to be fighting for flu and any vaccine. Thank you.
Thank you, Dr. Rania. That was a very interesting discussion, and I think it helped bust a lot of myths that people have with respect to vaccination. And like you said, this year more than ever, we need to be pro-vaccines, and we need to count and hope that not just the routine vaccines, but the new vaccines that are coming up now for COVID will help us fight and get back to normal. So thank you very much. We have a large number of people in the audience, so I would just like to ask if anybody has any questions, you can please put them in the chat box, or you can even raise your hand, and I will ask you to ask your question. In the meanwhile, we have started posting the post-test and the evaluation form in the chat box. So please fill those because they are essential for you to get your attendance certificate. There is a question about patients on steroid treatment.
So it depends on the amount of the steroid or the dose of the steroids that they are taking. If it is a high dose of steroids, we would like to postpone the vaccine if feasible. So if he is on a high dose of steroids for a very long time, or it is for the vaccine that is meant to be given is a vaccine at the time of an outbreak, this is a precaution and it should be given. But if it is a low dose, there is no harm of giving the vaccine even if he is on low dose prednisone or glucocorticoid.
Okay, thank you for that. There is, I'm still trying to look, there's a comment from Dr. Huda that you gave a very fantastic overview. So
thank you. Thank you.
And also from Sanjay Vyas, he said that it's a very informative session. He's happy with the session. They still look, if anybody has any questions, if you've had any issues with vaccinating your patients, counseling the parents, and you want to ask Dr. Rania anything about that, please go ahead and either raise your hand or put it in the chat box. Dr. Saima and Annalyn Vera have also thanked you and said very informative, clear and concise. So thank you very much, Dr. Rania, for that.
It is good to keep in mind that the take-home message is if you are ready, the patient will take the vaccine, because they all have the fear, but they like to hear from the doctor that they are sure that there is no harm because of that. And this reluctant parent would respond if the doctor is fighting for the vaccine. Even the most resilient not to take the vaccine, they would respond if you keep pushing. And this is our job.
Excellent. So somebody has asked, what about children with genetic problems such as trisomy?
They are regular patients and they should be taking the vaccine regularly and normally. There is no interference with the response to vaccine from the patients with genetic diseases.
And Dr. Kavya wants to know that what if the child's parents are immunocompromised? Any specific vaccine to be avoided?
Exactly. This is part of, I don't know if I can share again. It depends on which vaccine we're talking about and which, where is, it's okay, I will not share it. I will re-repeat the thing. If the parents are the one who are immunocompromised, but they are not recipient of stem cell transplant or having host versus transplant versus host disease, they can take the vaccine, no problem. The child can take the vaccine even if it is a live attenuated vaccine. These are the only two conditions. Then we have two options. Either we give the vaccine to the child and keep them away for 7 days, or postpone until the recipient is past 2 months post-recipient of transplant.
Okay, thank you for that. Dr. Huda wants to know, what is the prevalence of anti-vaccine people in the UAE? Do we have any idea?
I don't have statistics, but I can say that we have lots in the clinic, lots coming. They're not anti-vaccine. They come, they don't want the vaccine, but they go out with the vaccine at the end because your job is to convince them.
Okay, excellent. So thank you for that.
Can I ask Dr. Rania, thank you so much.
Yes,
a very
please.
informative session. One of the challenges we feel, we experience in the clinic is when we come across this experts, especially, people have started a primary immunization in their home countries or other countries that they were. And then even, for example, in Dubai and other places, and then they come to the clinic and they bring their card and they say, what can we do now? Because they are somewhere in between. They're in limbo. They've started the vaccinations there, and those vaccinations are not with the Abu Dhabi, recommendation EPI immunization schedule. So where do we exactly stand in those situations? Because some of them have been taken and some are not, and then the parents worry that maybe they will be duplicated or they will get the additional vaccines. So is that something I'm sure you've come across also in clinic?
Very nice question, because it's very challenging to approach the parents. Some they need to continue, they insist on continuing their home land schedule, which I always advise the parent not to do. Even if you are going to go there and there is a vaccine that is extra on top of what we are covering in here, I will offer that. But the schedule as it is should be covered according to the country where you are living, because it is done according to the statistics of the infections that are most common in this area and the probability of you getting that disease. So I always advise them to go on a catch up, to go back to the schedule of the UAE. And if there is anything additional, like Europe, they do use the Meningitis B vaccine, which is not available in here. I advise them to continue that with their home country whenever they are on vacation. But the regular schedule of vaccine of the UAE should be followed, because this is where they are exposed. This is where they are living currently. And that's, we make a catch up to complete what they started, or initiate what was not started.
Yeah, thank you. Thank you. That's useful to know. Thank you.
Thank you, Dr. Rania. There is another question about by Dr. Ibtihaj. What is the relationship between vaccination and psoriasis?
Well, psoriasis, we know that any stress can be triggering the psoriasis. And it is not the vaccine by itself that can be triggering it. It's the stress of anything. The stress of an infection can trigger it, like the stress of an immune response that you are mounting with the vaccination that triggers it. But that does, again, not prevent you from giving the vaccine. We treat whatever we can treat of the psoriasis in collaboration with the dermatologist, but at the same time, we don't avoid giving the vaccine.
Thank you, Dr. Rania. Another question is about autistic children. Are you still recommending routine vaccination for them?
This should not be asked, because theoretically, all what I was trying to say is that there is no relation between the vaccine and the autism. Whether they have it or they don't have it, the vaccine is not going to make you autistic at all.
Excellent. Thank you for clarifying that for somebody who might have missed it. Now, what about, somebody's asked, what if the vaccine has been delayed for some reason? What effect does this have on the child, on the immunity, on the program?
Definitely, if we are delayed, we are at risk of contacting the illness, and that's why we have what we call a catch-up schedule. And the catch-up schedule does not wait the same time as the regular vaccine schedule. So we shorten the interval to mount a better response in a shorter time for those who missed any vaccine.
Okay, so that's I guess every doctor can individualize and see the schedule, and then excellent. Somebody has asked about the influenza vaccine. If you can tell us a little bit more about that, and specifically they want to know at what age can the nasal influenza vaccine be given annually?
Well, the nasal influenza vaccine is not of the regular that is available here, but I know that it is of the regular that is in use in the States, and they use it from the age of 2. We here use the injectable influenza vaccine yearly. And what they want to know about the vaccine?
At what age can the nasal?
Yeah, this
vaccine?
one I did, but there was another question
about that's it. They just want to know more about it.
But it's not in use currently here, but I know that in the States they use it regularly because it's easier.
Yeah, yes. There is a question about COVID vaccine. I know that's not a part of the topic today. It's only about routine vaccination. But do you have anything to add for that from?
Maybe Dr. Samina can help with that more. She is the one more involved in this vaccine. So far, studies are ongoing for children. There is no full studies that are available to talk about the vaccine for children. It will be ready soon. I am sure it will be launched for children very soon. But until now, it is in Dr. Samina's hand, not in mine.
Dr. Samina, would you like to add anything?
I'm sorry, what is the question, Neha? What
Any vaccination myths about COVID-19 vaccine that you would like?
Oh, lots of it. You can write books on it. And there are lots of myths about it. And depends on which one you're taking, which make you're using. I can just speak about the Sinopharm, which is the one that is used in Abu Dhabi. And so far, the vaccine, more than 100,000 people took it at the time the vaccine started in trials and other, initial vaccinations. And so far, no serious adverse effects have been reported as per Abu Dhabi Public Health to this vaccine. So generally speaking, when we are giving in clinic, it is generally seen as a safe vaccine. So that's in a nutshell.
Okay. Thank you so much for that, Dr. Samina. Dr. Rania, coming back to you, there's one more question about moderate to severe asthma. Is that a contraindication or a precaution?
It's not a contraindication, it's not a precaution, it is an indication. Those asthmatic are at higher risk of pneumonia, so they should be taking their pneumococcal vaccine on time. They are more at risk of influenza complication, and those are the target population specifically for the influenza vaccine. There is no precaution for that unless they are currently on high dose of steroids. And when they are on high dose of steroid, it's a short time, and we can just have a little delay of the vaccine for the time when they are on high dose of steroids. Otherwise, they take their vaccine regularly.
Okay, thank you. A lot of questions are coming on the chat box about the pre-test and the post-test. So it's being sent on the link, but pre-test we had expected you to finish before the session. So I would now just ask the team to post the post-test and the evaluation form link again. So those who haven't done can do it now. Another question is why is there a difference between private and government hospitals schedule? Is there such a difference of vaccination? And
no, private clinics follow the DOH schedule of vaccination regularly. There are few non-mandatory vaccines that we offer to the patients. Sometimes they like to take according to the countries they travel to. So here, let's say the hepatitis A disease is not common. That's why it's not of the routine immunization schedule in the country, but there is lots of countries who are high risk for that. So we do offer this as an additional vaccine. The meningitis is another additional vaccine, and it will very soon be incorporated in the early months of age schedule in the DOH, and then it won't be any different. But actually, we follow the DOH schedule of vaccination.
Okay, so that's clear that. There's somebody has commented that they've observed that there's a low rate of influenza this year. And is there a relationship between influenza cases dropped to the COVID vaccine or to COVID, although not everybody had the flu shot?
Actually, there is no real study. I was looking for that. No real study looking at why there is no influenza. But if you think logically, people are wearing masks, washing hands, and this was the precaution that they need to do to stop the influenza. So while stopping the COVID, by mistake, we stopped the influenza.
Well, that's some plus there.
At least something good.
Yes. Somebody who is a school nurse has commented that they think it will be very hard to convince parents to give COVID vaccine to their children while we are still arguing about convincing them about routine vaccination. Do you have any tips or suggestions for that?
We'll have to wait until we have the results of real studies in children about the COVID vaccination. And then when you have a strong data of results, safety, immunogenicity, and response to the vaccine, then you can convince parents better. At the end, you have to put the data in front of the parent and tell them, this is what we know, and this is considered to be better for your child, and they will have to decide at the end. I know I usually struggle with the school nurses to convince parents of the routine vaccination. But again, if you have the knowledge, if you have the data, you provide them with the data, and most likely they will accept the vaccine.
Excellent advice. Thank you so much. Again, there's a question on flu vaccine about flu vaccine for children every year. At what age do you recommend that is started?
We start from the age of 6 months and ongoing. Those who goes to nursery are the target population because those are the ones who does not know how to take the precautions. They put everything in their mouth. So this is the age that is most important to vaccinate. But anybody after the age of 6 months can take it.
Okay, excellent. So after 6 months, annual vaccine, flu vaccine can be given. Somebody wants to know a very important question, which is which vaccine is most painful for babies?
The DTP, because it mounts an induration at the site of the injection, and the pain is immediate. So the induration happens just few minutes after you finish the injection. So you would see them going out still crying, while the others will go out. They will cry while the injection is given, but then they forget and they reach the door of the clinic smiling and happy. While with the DTP, they keep crying because it causes induration at the side and they feel the leg being numb and hard to walk on. But so, it's a tolerable pain.
Okay, anything to be done for that? Any tips for that? Or
Yeah, we
it's
usually ask them to apply some ice packs on it. No, don't hold the child on the DTP and squeeze there, because that would be painful. Just to carry them on the other side. That's why we always tell nurses, always give it on the left side, because parents would know that this is the side where the painful one is given, and definitely giving some paracetamol for the control of the pain.
Okay. There's another question from Nisha. All vaccines almost have some side effects or after effects. So she wants to know why COVID vaccine is different. Why is it being feared more?
It is feared more because we did not have yet data. So we know that the influenza have been in use since the 1970s, and we have already knew all the side effects, all the short-term and long-term side effects. And we know already how to deal with these. What are the contraindications? What are the indications? While with this one, it is under study. So this is the time when we learn from it. And this happened again also with the influenza vaccine when it was early introduced in the 70s. So this is how science is. We learn and we improve after we learn. And this vaccine is not any different from others.
Okay, thank you. There are a few people who are giving questions about the COVID vaccine. So I would just like to make it clear for everybody that this session is about routine vaccinations. We are not talking about the COVID vaccine yet. And as Dr. Anya has repeatedly said, it's still under study, it's still data still being collected. So we'll leave those discussions for another session maybe with Dr. Samina on a later
Whenever
date.
the studies in children will be ready, I promise you another session about it. I'm following it very closely. And as soon as we have real data about the COVID vaccine in children, we'll have another session.
We will do that for sure. There is a question about any effect of analgesic on the vaccine efficacy.
No, but why this myth? This myth happened because people think that if you have a higher temperature, then you have a higher or better response to the vaccine. Mm-hmm. And that's why dropping the temperature by using the analgesic will decrease the reaction, which is not true.
Okay, that's very clear. Thank you. They also want to know what is the mechanism of development of immunity in recipients who are already immunosuppressed. So they want to know how, is there a different pathway mechanism?
Understand? No, not different. That's why if it is a B cell deficiency, B cell immune deficiency, that's why we will not mount a good response, and that's why we will not take the vaccine or will delay it. But the mechanism is the same like in anyone.
Okay, so yeah, I think the person who's asked the question, if you want to know more, please write in the chat box. Again, I will not ask the COVID-19 vaccine related questions here. So please excuse us and please wait for the next session by Dr. Anya and Dr. Samina for that. Yes, so I think we have covered all the questions that we have received till now. And that has been a very, very informative session and a very interesting discussion. I will just wait for a minute more in case somebody has any other last minute questions. So if you have any, please write them in the chat box. In the meanwhile, please complete the post-lecture assessment and the evaluation form. It will also be sent to you in an email. If you have registered with your own name, email, and you have done the pre-lecture, post-lecture, and evaluation form, only then we will be able to send you by email your certificate of attendance, which is category 1 hour by DOH. But please make sure that you've done these surveys so that we are able to send it to you. Otherwise, as per DOH rules, we cannot give you the certificate of attendance. As far as access to the full discussion, we are working on that. We will not be able to send you the presentations directly, but we are working on how to have these available as videos later. And as soon as we have that worked out, we will let all of you know. The post-test link we will post again, and we will send it to you as an email as well. So I think that is all the questions there. If anybody else wants to ask, there's just a lot of comments that they're very happy with the session and they enjoyed it. And so that is good. Okay, so that is, I think we can wrap up the session now, Dr. Anya. If you have any other comments or
Thank you very much for everyone for taking time to attend today while it's early in the morning. And I wish everyone a good day to start with.
Thank you so much. Thank you everybody for attending. And we'll see you in a couple of weeks to talk about celiac disease. So have a great day, have a great weekend ahead, and see you soon. Bye. Bye, Dr. Anya. Thank you.
Bye.
Thank you, everybody.